Hello, everyone. I'm Dr. Rita Roy, CEO of the National Spine Health Foundation. Welcome to Spine Talks, where we bring unparalleled access to world-class experts like the professionals who are joining me today. I'm at the North American Spine Society's annual meeting here in Los Angeles, and I'm delighted to have these individuals join us for an inside look into what the professionals do at their society meetings. Joining me on the panel today is the president of the National Spine Health Foundation Board, Dr. Tom Schuler, who will serve as our moderator and will introduce our guests. Tom?
Thank you, Rita. This is truly an honor to be here at this meeting. This is at the North American Spine Society, the global leader in spine education to professionals. And I'm joined by three very distinguished men. We have Ed Doring, one of the past presidents of the North American Spine Society. And we've got John Finkenberg, who's just finished his term as president of the North American Spine Society. And Eric Muehlbauer is here as the executive director and has been so for almost 3 decades. So, gentlemen, if you could do a favor for the public and just let them know your background and where you work and your tie to the North American Spine Society.
So my name is Ed Doring, and I'm an orthopedic spine surgeon practicing in Scottsdale, Arizona, where I've been for almost 30 years, and did some training early on with some very distinguished spine surgeons, and they're the ones who convinced me that this was an area that I would want to pursue as a profession. And as I got more involved in being a practitioner with my patients, I just realized that how much goes on behind the scenes in terms of trying to provide education for surgeons so that they can be better surgeons. And I started getting involved in the North American Spine Society. I've been involved for 20 years and just had the pleasure of serving, the honor of serving as president. And I think we're going to talk a little more about some of what North American Spine Society does today.
Great. John
Finkenberg. I'm an orthopedic spine surgeon out of San Diego, California. I'm born and bred and not in LA. I was born in New Jersey, of all places, East Coast. That's where the majority of my family is. But we've been in California since 1959. And I did my undergraduate degree at UCLA. I did my medical school at UCLA. And I did my training at UCLA. So it's always fit that we're having our national annual meeting in Los Angeles. But I just finished my presidency for NASS. I did my training, as I mentioned, all in California. And then interestingly, I looked for one of the top 5 spine training areas in the world. And one of them was with John Kostwick in Toronto. So I originally had planned to go to Toronto, talked my wife into going, and 3 months before I was supposed to go, he called me and said, we're moving to Baltimore. And so I ended up doing my training as one of his first fellows at Johns Hopkins in Baltimore. It turned out to be an amazing training, mainly because they really marry the neurosurgery and the orthopedic department together. In fact, I think John Kostwick had professorships in both of those departments. But it gave me the best way to go after spine care with the benefits of both specialties. But then right during my fellowship, because John Kostwick was so involved with North American Spine Society, I became a member right away. So I've been a member for, 28, 29 years. And then I just realized that since it is probably one of the biggest, if not the biggest, spine society in the world, and so multidisciplinary, that I needed to sort of check out different committees and try to figure out how I could get involved. And I did that for a long time. And as you do that continuously, you keep moving up into the committees and councils. And before you know it, you're president.
Eric?
Yeah, so I'm Eric Muehlbauer. I'm the CEO of NASS, and I have a quote that I use. So, volunteer work is like a soft, easy chair, easy to get into, hard to get out. So I've been at NASS 29 years. Had the privilege of working with these guys really closely for the last several years. I know John Kostowick too, so I know a lot of the mentors who have trained these guys. It's my background. I majored in international relations from Knox College. My first airplane ride in my entire life was courtesy of the CIA. I can't tell you any more about that. I was a state champ in high school football. I have a law degree from Loyola University in Chicago, studied really medical malpractice is the best way to phrase that, and studied nonprofit management at Harvard Business School. So I get a lot of questions about spine from patients. And so having this unique place where I've seen the field for 29 years, I think I have a pretty good read on kind of the sequence or the protocols that one might avail themselves of if they have a spine problem. So, there's orthopedic surgeons, there's neurosurgeons, there's physical medicine docs, anesthesiologists who do pain management, there's McKenzie practitioners, there's chiropractors. There's a wide gamut of options for a patient. And so I've seen a lot of the pros and, given any particular situation, I've been able to guide people to the right practitioners over the years.
That's great. So, we're here at this meeting, and I want to dispel right out of the gates any myth the public has, because sometimes people think, oh, meetings are just a boondoggle, you're going to play. And I think that the amount of work and the knowledge that is gained at these is enormous. So considering you're just finishing your presidency year, John, I'm going to ask you just to comment a little bit about how much work goes on and what we're really trying to achieve at these meetings.
All right. Fresh in my mind, trust me. Well, when you, and we decide this a year before the meeting takes place, the president has an option of picking his program chairs. And it's done in different ways with each president. Typically, it's 2 or 3 people. I actually chose 5. And I did it for the reason that I wanted to do it a little bit in the proportion of our members, because really the Orthopedic Spine Society is almost 50% orthopedic spine surgeons, 25% neurosurgeons, and then the rest of the 25% are physiatrists, maybe 15% radiologists, anesthesiologists, chiropractors, physical therapists. But I wanted to get 2 orthopedic spine surgeons, 2 physiatrists actually, and a neurosurgeon as well. And typically, put 5 doctors in a room, you won't get consensus on anything. But this group worked very well together. I mean, almost faster than we've ever done it before. I think in 1 or 2 meetings, we had set up the schedule and what was going to happen. Now, setting up the schedule and actually enacting it is a whole different thing. And that's where the NASS staff and Eric get involved, because you pick the papers. We had over 1,600 abstracts this year, and these are papers that are in the process of being done or finished, actually, and submitted for review and to see if they can be accepted to the meeting. And it turns out that I think almost 150 were podium presentations, many were poster presentations. But this is all the hard work that people do to advance our knowledge in spine. And it's interesting because you're right. People do think these meetings are boondoggles, but the reality is many of the doctors come with their spouses, and their spouses never see them because they're at the meeting trying to learn more about what's new in technology, new in biologics, and where we're going from here. So it's an incredible amount of work. NASS staff has to take the credit for it because we're all volunteers. And this year, I think we had 4,500 attendees and half industry and half members. And industry's been very happy with how it's gone. Interestingly, they use the meeting to talk to one another. This is something I never realized until I started talking with them. And so, yes, they want to talk to the physicians, but they also want to talk to other industry people.
So this is the biggest meeting of the year, but you have meetings all over the world all the time, Eric. So how long is this meeting in terms of the educational session?
We start officially, we have a coding course at the beginning of the week, and that's just people who want to go for that portion of it. Then Wednesday through Saturday at noon. And John's right, we had 1,688 abstract submissions, which are just brief synopsises of people's research. And then what we do is we have a panel that reviews all of those abstracts. 5 people review every abstract, and they're rated, and so that they're ranked. So only the top ones, the best research, gets on the program. And so we had, I think, 210 podium presentations, about 150 posters. So of the 1,600, there's only about the top 400 who have a forum here. We do have other programs. We do hands-on courses. We do injections courses. And like Dr. Schuler said, our mission is to improve spine care. And we do that by making sure we've got a multi-specialty group of people, orthopedic surgeons, neurosurgeons, physiatrists, pain management folks, looking at the same information. And then they kind of work together to figure out what's the best use of this information. That's how we come up with guidelines. That's how we come up with our education programs. So it's a multi-specialty approach, and I think it's one of the strengths of the society.
And if I can just contextualize that for the public, I think one of the things that Eric is laying out here is that, when you are going to choose a doctor and you ask yourself, how do I know that I'm in the right place? I've chosen the right surgeon or the right specialist for my needs. I mean, one of the things that you can look to is whether or not your doctor participates in professional society meetings, because this really is where the exchange of knowledge happens amongst professionals. And I think one of the exciting things about NASS is that everyone's been talking about multidisciplinary, and sometimes people don't really understand fully what that means. And that just means different kinds of experts are sharing their expertise. So whether it's a surgeon or it's a pain medicine doctor or other specialties, they're sharing their knowledge with each other to give the best possible outcomes for patients, because there are so many treatment alternatives that people have. And I'm just so delighted to be able to participate at NASS, to be able to bring that information to people and to patients.
One comment, Rita, I want to make is that we often don't work apart. Having a society like this makes us realize that how we use pain management is the best way, and how we use our physiatry departments. And it is not infrequent that neurosurgery and orthopedics work together on cases.
Yeah.
So that ability for us to be collegial and work and understand each other's strengths makes it better for the patient.
Yeah, and one of the impressive things that I've seen happen at the society meetings, and including NASS, is that the doctors don't shy away from controversy, because there are so many opinions. There are many different ways to do things. And Eric was talking about the abstracts and the papers presented and the podiums. What all of that means is that that's the evidence development. That's sort of like, well, how do you know this is going to work for me kind of thing. So we talk about evidence development in medicine, evidence development in spinal healthcare. This is where that science is being vetted by the expert panels. It's being vetted, it's being presented, it's being shared, it's being discussed, it's being questioned, and consensus gets arrived at, and then it gets reviewed again, and that sort of goes on and on.
And in addition to the scientific research that's presented here, we'll also have case studies where a person's x-rays, MRI are put up on the screen in front of 100 or more people, all representing different areas of spine care. So surgeons and chiropractors, physical therapists and pain specialists. And it's very interesting because science is not black and white. It's not absolute. And there are cases where if all I know as a surgeon is surgery, it's like I have a hammer and everything's a nail. And it's that old phrase. However, what if somebody else says, well, that's not really a nail, that's a screw. And I'm thinking, wait a minute, No. This is the way I was trained in my residency in medical school, is to approach it this way. You're telling me there's a different way to approach it? Well, let me hear about that. And if I start to be involved in this kind of symposium, which we have a lot of here at NASS at the annual meeting, I will start to think, well, wait, maybe my patient should have another kind of care before we consider surgery. Because my training didn't focus on that. But a meeting like this helps train me to be a better surgeon by being a better physician, looking at the totality of that patient's care. And I think this is what we're all talking about when we talk about multidisciplinary and what kind of education goes on. This is one of the very few multidisciplinary organizations focused on spine care.
That was fabulous, Ed. I think the important thing for patients to understand, the public to understand, is that we go through a lot of education till we get out to practice. And I can speak about my own experience. It was 4 years of college, 4 years of med school, 6 years, 5 years of residency, a year of fellowship. So 14 years after I graduate high school, I walk out and I'm a fresh doc. And guess what? I don't know as much as I need to know. And it's through these organizations continuing education on an annual basis that we can stay current in terms of what is important for our patients and how to better improve. And so I want to take a quote I heard from a great lecture yesterday that said that we don't do at the start of our practice and practice the same way as we do at the end of our practice. And it's because of two things, John. And you said experience and technology. So do you want to comment on that?
Yeah, I mean, one of the pillars that I think is very important in medicine is being able to still practice the art of medicine. It's never black and white. Each patient is an individual. Each set of symptoms are different than the next patient. Ed will tell you, he can't tell you the number of patients that come in. Well, my aunt had this thing done to her, so why can't I have the same thing done? And the reality is your symptoms are completely different. Your x-rays look different. You're not a candidate for what your aunt had. But yeah, it's important that we try to understand that medicine is always evolving. I mean, we have new technologies, we have new procedures, we have biologics, we have new materials that we work with. And then navigation and the way we connect the navigation with CT scans and computers is making everything very different for especially advanced reconstruction spine surgery. Because we often see cases or patients that have had their third or fourth procedure and their anatomy is nothing like the books we all learned and tried to figure out how to do the procedures with what we call, a virgin back that has never been operated on. So that's where experience comes in. And I think you change your philosophy on how you approach things, how aggressive you are, and maybe how with experience, when to pull back, when to maybe go after specific things that are bothering that patient without trying to make your x-ray look like the most symmetric and complicated procedure possible. So
that's fantastic. So when you take a look at this panel, I think it's important to understand that you have a bunch of really old people up here. And so we have over the three of us on the right side of this panel I'm talking about. But you have over 30 years of experience as spine surgeons in each one of us. So we're looking at 90 plus years of being experts. And I think what is truly amazing is we have transcended from the dark ages of healthcare into this modern environment where we can do so much to improve people's lives. And that would not be possible without the technological evolution, but the use of meetings like this to disseminate the research and the knowledge so that we can provide the best care for each patient. And that's what these societies are about, is educating the providers so that we can get the best health care and the best results for our patients. So do you guys want to comment on that?
I'll comment. Yeah, I mean, well, the other thing people have to know is that before everybody gives their talks, they give a full disclosure and transparency about their association with the instrumentation, the company, and that makes everybody understand where they're coming from. And if it's something that's not FDA approved, it's discussed and told. You want people to understand that, hey, this is new technology. I want you to look at it and see if what we found could maybe be helpful in some other field that you do. I sat and watched a talk on a facet replacement procedure that sort of is a mix between a facet replacement and a disc replacement, and I had never seen anything like it before. And somebody from another country said, I think that's an interesting concept. I think I can spin off that to do something else. And that's the only way you would be able to understand something new that you can maybe apply to your patients in the future. So that's what's so wonderful about these meetings.
Good, Eric.
One of the other key things about NASS is we have a really robust ethics program. So Dr. Finkenberg and Dr. Doring, they're not allowed to have any current consulting relationships. They can't be involved in industry. Our program chairs are the same way. Our board is the same way. So we've tried to manage any of those complications in terms of what might be perceived as bias up front. So interestingly, I think what happens is the society has built a lot of credibility. And one of the groups that we have some of the most credibility with are the payers. So insurance companies, we develop things called coverage recommendation documents. They're evidence informed. We also do clinical guidelines. But the insurance companies look for our coverage recommendations, and then oftentimes they adapt their policies because what we've promoted is fair for doctors, it's fair for patients. And part of our job there is to ensure access, right? The other thing we do within several of our committees is we require them to have EBM training. So that's evidence-based medicine training, so that when they're looking at an abstract or a paper in a journal, they can look at it critically. And so they can figure out what to promote. There's a doctrine, a legal doctrine in the medical field. It's called the learned intermediary. So these guys are here to learn about the latest in spine care from others who've done research. Part of their job is to be that learned intermediary. They've got to interpret what they're reading about a facet joint or something else so that they are best equipped to talk to the patient in terms they understand about the latest research. So it's a vital role that a lot of these doctors play. And doctors who come to these meetings are committed to staying up to date with the latest techniques, trends, and research.
And one of the reasons why we are so excited at the National Spine Health Foundation to partner so closely with NASS is our mission is to do the patient education piece of it. And so, and to advocate for greater access to care. And NASS is the organization that's leading those efforts and doing the work to get payers to cover procedures. And so from our standpoint as a patient advocacy organization, we want to support that work. We want to bring the patient voice to that work so that everybody can have access to excellent spinal health care. And that doesn't happen in a silo. That happens through so many partnerships and people working together to really push for those things to happen based on evidence, based on science, based on what's best for the patient.
Go ahead.
In talking about technology, new technology, patients may hear about using robots in surgery or perhaps what stem cells or even PRP. There's a lot of new things out there. And at a meeting like this, it's an education meeting, but there's actually an interesting tension of sorts because something new comes out and people get excited about it. And what we try to do at a meeting like this is say, what is the science behind this new technology? What do we know is accurate about the ability to use it? And sometimes we'll have a very interesting presentation from someone who's on the forefront of this technology, but at the same time, we haven't had enough research, enough science to know that it's safe for patients. But we all come away, as John said, with, okay, there's a really good idea, and I'm thinking about how we might be able to use these ideas in our practice. But again, for patients, it's important to know that sometimes you'll see marketing of new technologies that maybe haven't been quite fully vetted yet. They're not proven. And sometimes we find out 2 or 3 years later, it was the greatest thing, since sliced cheese, as they say. And bottom line is if you were an early, patient to get that worked out great. But sometimes we find out, wow, this causes problems. We see where it actually causes damage or a greater chance of a complication. And now that the science is in, we back away from it. So I think one of the most important things that we try to do in our meeting is to convey the ideas, but also convey the pros and cons. Where are we maybe going to be in 2-3 years? Is this ready for prime time? From a patient perspective, I think if you're seeing things, if you're reading about things and they sound really good, the web can be all sorts of great information. It can also be all sorts of great misinformation. So it's good to get multiple opinions. I just took care of a patient who had, I can't go into too much detail, but a procedure touted not allowed to be paid for by insurance companies because there's not enough science. And that procedure caused a terrible infection. And the patient had to come to the hospital, and he had not done, very smart man, but he had not done much research or even tried to get a second opinion before he had this injection. And so these are the kind of things patients should be aware that in our field, there's science and accepted things, and there's things that may be great, but we don't know yet. And so just always a good idea, get more than one opinion from more than one specialist or more than one surgeon. If you're a single specialty, get that information so you can make a wise decision.
Dr. Doring, thank you so much for saying that. We talk so much about the need for patients to have informed decision-making. And, spinehealth.org is a site that we work with you all to provide unbiased, vetted, honest information so that patients can get informed. It's a great location to go, and working with NASS, working with the Medical and Scientific Board to bring good information so that you can take questions to your provider.
So research is presented at this, and there's a lot of concepts that come out to try to advance spinal health care. And I think it's important to understand how long it takes to get this research to a stage that it can actually be presented at a meeting. So, John, do you want to just kind of comment on how long each project, 1,600 papers, how long are the doctors working on those projects, those papers, before it actually gets to the point that it can be presented at a meeting?
Well, first of all, people have to understand that there are various steps you have to go through to get an FDA approval. And it's a type of study that's being done. It can be what they call a level 4, level 5, which is sort of anecdotal information, versus a level 1, which is prospective, multi-center, randomized, controlled. And those are the studies that we really want to focus on, because those are the ones that are done in the best scientific way to give us accurate information that's not biased. And so for people to apply for a new technology or whatever, they have to go through the government, and they have to go through multiple clinical trials. There's a drug called Riluzole that's being used to help people with ALS. The FDA has approved it for that, but we're finding out it might actually have some benefit for patients with spinal contusion. And that turned out to be what they call a sodium glutamate antagonist. But what it does is it decreases the edema and the nerve as a result of closing off channels for sodium to get in, and also closing off channels for calcium to get in, which actually kills the cells, which makes the recovery not as good. So that's in a class 3 or a stage 3 study. And so they've gone through 1, 2, and 3, and these are studies that go over years. So it's complicated, but it's good that it's done that way, because it's rigorous and we get information that we can actually use and trust.
Yeah, and those are FDA studies, which most of the research is not an FDA study here. It's just science. But my own experience from the presentations I've been involved in, it's years of work that ultimately get to the point that we can present a paper to get it hopefully accepted and then present the data. So it's a long. So your experience?
We're just going to add one thing, is that some of the papers are basic science in nature, and maybe they can be done a little quicker. But the clinical papers, those that are about patient care, Those papers we typically require as a minimum. If something's done to a patient, how is that patient doing at least 2 years later? 2 years is kind of a cutoff to let us know, okay, we don't have any complication or side effect that's happening a year later that we wouldn't know if we just visited the patient in the hospital and they say, I feel great. So we try to, these papers are not only taking several years to bring patients in and try a procedure, but then following that for at least 2 years later, again, so we can have good information as practitioners about what it is that we can advise our patients, but also patients can have a little more security that this is a procedure that's shown itself not only to work short-term, but long-term.
Dr. Doring, thank you for mentioning the clinical research versus the basic science research. The foundation is involved in clinical research work, and one of the things that's so important is that we can follow patients over time. So we try to do a really good job of explaining to patients when they are enrolled in a study that they're helping to contribute to the advancement of knowledge and the advancement of science by participating. Because oftentimes, I know myself as a patient, I was enrolled in a study and you think, well, I just want to get through this. I want to get through the pain. I want to get better and be done with it and go back to my life. And that's true for all of us. But it can be so helpful to the future of science if you can just stay involved in answering those surveys that come across, a year later, way after your surgery is done and you've gotten back to your life, you've gotten through your recovery. But to continue to fill out those surveys and let people know how you're doing is so important.
Rita, to add on to what Ed said, we follow studies out to 10, 15 years sometimes. For instance, disc replacements, we receive the information at 2 years, and then we get another paper at 5 years, and then another paper down the road. So we really have a chance to see whether it's working as good as we hoped, and fortunately, many of them do.
Well, it's really important to notice also that FDA is a legal standard. It's a regulatory standard. It's actually a low bar. Getting over that is you just have to prove safe and effective, right? Insurance companies have a different criteria for whether or not they're going to pay for something that's reasonable and necessary. So if I'm developing a new product, FDA is the first hurdle, of course. But what I'm really after is insurance company acceptance and physician acceptance. Because if they reject the technology because the studies that you've done are not good enough, it's not going to make it into market. So when we look at these 1,688 abstracts, we're looking for the best studies that have been done. And Dr. Schul is right. It might be a retrospective study of the last 5 years worth of patients who had one condition. That's really good science. And that's what these guys are going to be convinced by.
The important thing to understand is that when you're a patient and you're involved in an outcome study and you get those forms, please fill them out because you are advancing the field of spinal health care. You are helping other people get better, whether it's 1 year, 2 years, 5 years later. By us getting the results, we can then come back and fight to make sure that all patients have access to the best care, that we know what the best care is, and that we can do it. So I implore on you to do that. It's also a sign of whether your practice you're getting your care at is at the leading edge. Is are they doing outcomes research? Are they following it to make sure that we're continuing to advance the field of spinal health care?
And it's not because you're getting enrolled in something that's experimental. You're getting enrolled because your doctor really wants to follow how you're doing and contribute to this big body of science and evidence. And I think that can be confusing for patients. When a doctor says, I'd like to enroll you in a study, we'd like to see how you're doing over time, it doesn't mean that they're experimenting on you. It means that you're contributing to science and to knowledge, and that's just good for humankind.
And tying together what Eric and Rita are talking about is, we're talking about the study, but also Eric mentioned insurance company approval for things. So every insurance company has their own method of saying whether or not they'll let you have a certain procedure, whether it's a medication as a treatment or a procedure like an injection or surgery. And if we have this kind of information, then we can go as an organization, NASS will go to the insurance company and say, here is our body of evidence. Here's our scientific evidence that this works. Please allow patients to have this procedure or to have this medication. And again, if we don't have the public patients cooperating with getting all the data that we need, then, you may be part of a study that they tried it on, but we can't bring it to other patients. So again, as Rita's saying, I think it's very important when people have an opportunity to participate in these to do so.
So one of the important things is understanding that these professional societies like NASS and many others are constantly fighting for the benefit of the patients. And that's political advocacy to make sure that we have access to care. So gentlemen, I don't know who'd like to talk about it, but let's discuss NASS's efforts towards helping the patients through political advocacy.
Yeah, I'd be happy to say a few remarks. I was the advocacy council chair for about 6 to 7 years for NASS and had many opportunities to go to Washington, D.C. And people think when spine surgeons or doctors in general go to Washington, D.C., they're advocating only for their members and only for better payment, better work environment, and things like that. But the reality is we advocate for better patient care. If we can improve the quality of patient care, then all the other things will fall in place. And it's interesting when I talk to the congressman, if the conversation is directed on how what we are asking for will improve patient care, which, by the way, are their constituents who vote for them and get them into office, all of a sudden I have their immediate attention. And so that's how important it is, and that's why NASS puts it on a very high level of concern and importance.
Yeah, I would even add that, several years ago, we started something called a value committee because, there's lots of great technologies out there, but there was a dearth of information about the costs related to that and the benefits and the outcomes. So we started a value committee within the society, which is more of a business side of things. But what it did is it kind of became part of the DNA of the research that we see now. So not only are they looking at the clinical, but the value of it. And that resonates again with insurance companies because they want to see proof that, okay, if I say yes to doing this treatment, how is it going to affect outcomes and what's the cost going to be? So that's now part of all of the different types of research that the field does, including industry.
To build on what Dr. Fingerberg is saying, although we often go into Washington, D.C. and talk to congresspeople, or we'll meet them at our local state office so we can vouch for patients, the ones that are listened to the most are patients themselves. And I've had several times where a patient has had something within Medicare where it's not being approved. And I'll try to get that approved and I'll work on it. It's just not getting through. And the patient will write a letter literally to their congressperson. And especially if they see several letters coming through like this, not only are they going to maybe work on behalf of that single patient, but more importantly, if they see several letters, if they get several phone calls, several emails, now they're saying, wait, something's going on with my constituents that I need to address. And that's even more powerful than when a doctor walks in. So I would encourage patients who are involved in spine issues to be part of this by talking to your congresspeople. You're not going to maybe talk to the senator or congressperson themselves, but you're going to talk to their staff, and the staff will get the message through.
I think it's so important to understand that the physicians that are involved in these societies, as well as the society leadership itself, are very passionate professionals that are here to fight and get our patients the best care. And we use the knowledge and science we gain at these societal meetings to go forward, provide the care ourselves, but then also to fight through advocacy to get the best result so people can have the best quality of life. And that's really what we're about as ethical, bright, passionate healthcare providers, is getting the patients the best results. So one of the things that's essential for these meetings to actually take place is to have collaboration with industry, because industry comes in with the ideas, the technology, and helps fund the meeting so that they can exist. But it's done in a very neutral way, which is why there's total disclosures before every talk about if somebody's working with a company so that people can understand, is there potentially a bias there? So, and NASS and many of the societies have done a great job of mandating that as part of the process. But the real question is, what impact does industry have on the advance of the field, and how does that relationship work with the societal members and the physicians?
Well, you have to understand that research and development is a big part of every industry. And everybody assumes that everything they work on goes immediately to market and is produced. And the reality, the things that actually turn out to be something we can use and are proven to be scientifically beneficial is a very small percentage, probably somewhere between 5 and 8%. So that means the rest of their work and efforts, not that they've gone to naught, but they've been very expensive and don't lead to profit for the industry. So what we try to do is realize that these meetings were a partnership with industry. They want to be here, and they want to be here in person. They don't want to be here through a virtual effort. They want a face-to-face interaction with physicians, with patients, because amazingly, there are people that are non-members that do come to this meeting and to find out information that they can use as well, which we promote, and we hope that occurs. But I think it's important that you understand that there isn't a good guy and a bad guy. Everybody comes to the meeting with a professionalism and ethics. And we've done that more and more over the last probably 15 to 20 years. So I'm happy where we are, and I think it's a good working relationship.
Brief comment, but just research is expensive, and there's only so much money that the government will provide to help us take better care of spine patients in terms of the research. If somebody at a company comes up with an idea that could really help patients, they will invest the money to do the research to show that it's going to help patients. And that's where this collaboration comes in, because we will work with industry. We have committees that work with industry to help them refine their research, to help vet what they're doing, and then to present it to other doctors. Again, the kind of discussion we talked about earlier, now doctors get involved and they're discussing this research of how it might benefit their patients, and it creates a little bit of a groundswell towards better patient care. And this is a very collaborative thing that takes place. And without our colleagues in industry, we would probably have 20% of the advancement in care that we have now.
Yeah. And I would just add that, this is the system we have. Government, like Dr. Doring said, doesn't fund a lot of research. So it's up to the entrepreneurs out there to figure out, hey, I have an idea for something that might really help a patient. And so they have to they're the ones taking the risk. They're the ones that have to do the research. It's the system we have. And it's the job of groups like North American Spine Society and National Spine Health Foundation. We're nonprofits. So part of our job is to make sure that what comes out of these meetings is the best science that can come out of it. So we try to manage the bias ahead of time. And everybody's got a bias. I like the Chicago Bears. Somebody else likes the Packers, unfortunately. So, but it's just the way it is. So everybody's got a bias. It doesn't mean that they're wrong. It just means that it has to be managed. So it's our job to try to manage those conflicts ahead of time so that when it comes down to brass tacks, the information that's presented at the meetings is viewed in a way that can be interpreted best for patients.
I think that it's so exciting to see how this field has changed in the 3 of our careers. And what we've really seen happen, and it's happened because there have been brilliant, passionate physicians, brilliant engineers working collaboratively to take their knowledge, their ideas, put them to the test, and bring it out to a product which is truly transformative for our patients. And we've gone from the point when we started our careers, and I'm speaking collectively because we're all at the same time in training, but when we started, we had very limited options that we could use on a patient to help them. We could have them do some simple therapy. We could try a few injections. We could do a little micro decompression or a major open fusion. And now today, we're using robotics and augmented reality and artificial discs, regenerative and various ablation procedures, different injections. And everybody has a different treatment option depending upon their unique situation. And it's happened because of the knowledge that's been generated and shared at meetings and driven forward the field to the point that we are truly at a wonderful, miraculous time in healthcare, that we can impact people's lives so positively and truly keep them moving and functioning, which is really what we as specialists want to see, is a functional moving patient, functional moving population. So we're just delighted to do it. And it's thanks to your leadership, thanks to the NASS organization, to create venues where we can get that information and share it with all the providers, and then ultimately bring it out to the public. I'd like to close at this time, this wonderful session, with just some pearls of advice. And mine, a little separate from the meeting, is just that it's important to stay active and fit, do your exercises, stay healthy, get your sleep, drink your water, work on your strengthening conditioning, and you will have a better quality of life.
Those of us who experience spine problems know that it can be very disabling, both at work and in your home life. And as you seek treatment, my strong recommendation is always get more than one opinion, and just try to seek out different options for how you can take care of the problem that you have.
My pearl is healthcare is a partnership. It's a partnership with your physician, with your employer, with your physiatrist, with your physical therapist. Don't go at it alone. Don't try to figure it all from the internet. Use everybody collectively, because that's the way you'll get the best care and the best outcome.
I would say that specialty care is quality care. When you have a problem, you want a specialist. You want somebody who's done a fellowship. You want somebody who's devoted their life to just this type of condition. Whether it's a knee, there's the American Society for Hip and Knee Surgeons. There's Hip Surgeon Society. Go to the NASS website, go to the National Spine Foundation website, and find a specialist. Because, again, quality care comes from specialists.
Well, it has been just absolutely awesome having these leaders join us today in the Spine Talks presentation. You know, we talk about healthcare providers, the 3 providers on this panel, who take the miracles of modern spinal healthcare and put them into practice every day to give the best outcomes for patients. And I also want to acknowledge the executive leadership of NASS. Eric Mulbauer has been in this role at NASS for 30 years. And that kind of leadership that drives the education, the knowledge sharing, is so critical to giving, again, the best outcomes for patients. And we want to sing that from the mountaintops, that there is good news in spinal healthcare. There have been breakthroughs in innovation and technology that give consistently good outcomes to patients, but there's no cookie cutter solution, which we've heard today. And thanks to the innovations that these gentlemen have all been part of, there are options. There are different ways to treat your specific problem. So make sure you understand what those options are. It is confusing. There is a lot of information out there, but we are here to help. And I know all of these gentlemen have dedicated their lives to making that information and that education and that access to care possible. And so I give my heartfelt thanks to everybody for spending their time at this busy conference with us today to bring you this information. Thank you, everybody.
Thank you.